webinar. My name is Kara Doctor. I'm from InSciTech, and I'm very pleased to be part of today's virtual educational event. Please be patient as we take a few minutes to allow everyone to get signed on. The presentation will begin shortly. It looks like we have a good number of attendees signed on. So again, my name's Kara Doctor, and I'm very pleased to be part of today's virtual educational event. The goal of today's presentation is for educational purposes. We are incredibly fortunate to be hearing from Dr. Okeanis Vaou. Also, Dr. Alexander Papanastasio will be here to answer questions as well. They are both of UT Health in San Antonio and they're going to present on focused ultrasound as a treatment option for patients diagnosed with essential tremor or tremor-dominant Parkinson's disease. Now, as questions arise during this presentation, please utilize the Q&A button. It's located at the bottom of your screen. We will have time after the presentation to answer all of the questions that are asked within the chat. So first off, I'm going to begin by introducing you to today's presenters. First off, we have Dr. Okeanis Vaou. Dr. Vaou is an associate professor of neurology at UT Health in San Antonio, Texas, and serves as the division chief of the Movement Disorder Center. She is also the vice chair of faculty development and wellness in the Department of Neurology at UT Health San Antonio. Before her tenure at UT Health, Dr. Vaou was the director of Movement Disorders and Deep Brain Stimulation Center at the St. Elizabeth's Medical Center in Boston, Massachusetts. And prior to that, she was on the faculty at Boston Medical Center at Boston University School of Medicine. She is a seasoned expert in treating patients with Parkinson's disease and other movement disorders. In addition, she is board certified sleep specialist, providing care for sleep disorders in patients with movement disorders. Dr. Vaou possesses a particular interest in deep brain stimulation and sleep disorders associated with Parkinson's disease. Her passion extends beyond clinical practice to research, where she investigates novel pharmaceutical agents, sleep, and genetics. Joining her today is Dr. Alexander Papanastasio. Dr. Papanastasio is an associate professor and director of stereotactic, functional, and epilepsy surgery at UT Health San Antonio. He specializes in surgical treatment for essential tremor, Parkinson's, and epilepsy. He studied biological sciences and music at Stanford University, followed by medical school at the University of California at San Francisco. He completed neurosurgery residency at Harvard University and at the Brigham and Women's Hospital and Boston's Children's Hospital, and then a fellowship at Yale. Dr. Papanastasio is a married father of two who enjoys spending time with his family, bicycling, and playing jazz piano. Welcome, Dr. Vaou and Dr. Papanastasio. Thank you both so much for being here and for presenting to us this afternoon. The floor is yours.
Thank you so much, Kara. I'm just going to share the screen with my presentation, so bear with me. And for everyone who I cannot see, thank you so much for being here for this presentation. We are going to spend the next 20-25 minutes to talk a little bit about tremors, to raise awareness and kind of like try to clarify this nebulous area of tremors. What is essential tremor? What is Parkinson's disease? And what is your tremor? Who may, of those of you who may have tremor, those of you who are on this webinar. So I want to just share a few faces you may know. I don't know at this point if you all recognize the similarity with these famous faces. They all had one thing in common. They all had essential tremor. Just to tell you that essential tremor is very, very common. And it has been, it is actually the most common movement disorder that we know of. And it doesn't spare anyone, not celebrities, not politicians, not actors. A little bit about the tremor. Here you see on the top picture a very characteristic way of someone with essential tremor who is attempting to draw a spiral. This is what it looks like. So what an essential tremor is, it's involuntary. It's very rhythmic shaking of the hand primarily when they're holding their hands in a particular position or attempting to grab objects, or such as a pen, or attempting to write. We also call it action tremor because that is exactly what it is. The tremor appears upon action and not when someone's resting their hands on their lap or on the table. Essential tremor affects hands. It can start in the hands, or it can also start elsewhere in the head tremor. Katharine Hepburn, who you saw in the picture earlier, she was well known for her little shaky voice and little shaky head. So we do see or hear a voice tremor as well in people who have essential tremor. And very rarely you would see leg tremor or trunk tremor. This tremor is progressive, but very slowly progressive. And in very severe cases, or even in moderate cases, we do see that the tremor interferes with activities of daily living. Now, what does it look like? What does someone who has essential tremor look like, and what is the significance that they have in their lives? We know that patients who seek treatment have difficulty with their everyday tasks. They have trouble with simple things, writing, texting or typing, drawing. When they have to eat with utensils or eat soup or drink soup, they have trouble with the spoon or cutting steak. Even getting dressed is a big task, buttoning their clothes, using zippers, etc. Anything that requires their hands to actively do movement or a task, that it gets in the way. The tremor gets in the way of them doing these. This tremor does subside with rest. So when you don't need your hands and you're just resting, the tremor goes away. And it also causes some difficulties in the patient's lives when it affects the voice, because a lot of the times patients have trouble being even understood because of the voice, the tremor they have in the voice. Sometimes they're also having a head tremor, and that is affecting their social interactions, or they're self-conscious about going out in public if their head is shaking a lot. So these are some things that are affecting the patient's quality of life. And this is what is key in, one, understanding the symptoms, where they're coming from, what the significance is, and also understanding that these symptoms, essential tremor in general, can be treated. So if your tremor is affecting your quality of life, your social interactions, your communication, either at work or at home, there are ways of treating this tremor. So definitely do not hesitate to talk to your doctor and talk to your neurologist. Essential tremor is a very common neurological disorder. Patients have trouble even drinking from a cup or a glass, as you can see here. It is often hereditary. It doesn't have to be, but it usually runs in families. So when you are seeing the doctor for the first time, or a neurologist, make sure that you tell them whether, your father had it, or a sibling has it, or your children may have it. So that is important information to convey and communicate. The typical ages of onset, they're usually either early on, around 10 years, or 19 to up to 20 years, they're in the teens, or a little bit later in the 50s and the 60s. Now, mind you, if somebody comes to the office complaining of tremor at the age of 50, that doesn't mean that he or she may have had this tremor earlier. It just got to the point that was so bothersome that they needed to see a doctor for it. This is also another key feature of essential tremor. Tremor is that it's often presents in both hands. Maybe one hand is worse than the other, but on the most part, it does present on both hands. Very rarely we do see it on one side, but on the most part, it's on both hands that it presents. We can see essential tremor presenting with some unsteadiness in the walking, and it doesn't have to, but it could be another symptom of essential tremor. The progression is very slow, and it's very slow that it gets worse over decades. Now let's move on to some other familiar faces, such as Michael J. Fox, Muhammad Ali, and late Ozzy Osbourne. If you recognize them, you may know that they all also had something in common, and that was Parkinson's disease. Now we're shifting gears a little bit. Parkinson's disease is well known for the prevalence of tremor. So when people hear tremor, they think Parkinson's, but not all tremors are Parkinson's. So what is Parkinson's? Parkinson's is very different than essential tremor, not only in how it presents, but also in what it is, what causes it, what the pathophysiology is, how it progresses, and the accompanying symptoms, as well as the treatment. So everything is different in Parkinson's. It is a neurodegenerative disorder, is a progressive neurodegenerative disorder. The main feature, the hallmark, is that the brain is not producing enough dopamine. In other words, the neurons, the cells in the brain that produce dopamine are not functioning well, and there's limited or decreased amount of dopamine produced in the brain. And that causes what we call the motor features of Parkinson's disease. One of them is tremor, very different than essential tremor. And this is what I want to focus here today. So we have what we call resting tremor. It occurs when the body part is relaxed, when the hands are resting on your lap, when they're resting in the armchair, when, in other words, when you're not using your muscles. The patients also have a type of muscle stiffness, which we call rigidity. They also move slowly. We call that bradykinesia. And some of them also have some postural instability. In other words, they don't feel balanced. They have some type of imbalance, and they complain of tripping or falling. These are the main characteristics of patients with Parkinson's. The tremor is also very, very characteristic to Parkinson's and very different than the essential tremor. It starts asymmetrically this time. In other words, it starts on one side, whereas with essential tremor, we have the tremor starts on both sides. It occurs primarily at rest. It can involve the legs and the feet. And the typical tremor, the typical resting tremor, is it looks like what we call a pill rolling, as if you're rolling your index finger and your thumb together. This is the type of tremor you may see in Parkinson's disease. Parkinson's is not as common as essential tremor. However, over 1 million Americans at this time have Parkinson's, and this number is estimated to double by the year 2040. So it is becoming more and more common, and you will have probably noticed this as we hear more and more about Parkinson's disease. Now, putting them side to side, essential tremor and Parkinson's disease tremor, they're different. We still call them tremors, but they're different types of tremors. Thinking about timing, the tremor appears in essential tremor. The tremor appears when you're attempting to use your hand by using a cup, by using a pen. In other words, activating your muscles of the hand. That's when the tremor comes out, and that's when it becomes worse. In Parkinson's, it's the opposite. The tremor comes out when the patient's not using their muscle, when it's in rest, and it decreases with action. In other words, the tremor will come on, patient's rested, and when they use their hands or when they want to show you, here's my tremor, the tremor will go away. That is in Parkinson's. In terms of which body part is affected, it's that there's also a difference between essential tremor and Parkinson's. In essential tremor, we see that the tremor is symmetric, affects both hands. We also see tremor in the head. We also see tremor in the voice. This can and is seen very commonly in essential tremor. In Parkinson's disease, the tremor only starts on one side and then moves over to the other side as the disease progresses. Rarely affects head or voice tremor, but it can. In terms of handwriting, we do see differences. In essential tremor, the handwriting is shaky, but the size is normal. Remember that spiral in my first slide? It was very shaky. You couldn't really tell it was someone attempting to write a spiral or to draw a spiral. In Parkinson's disease, it's the opposite. Think less movements. When they're attempting to write, the letters are small. We call that micrographia, and they're very crammed together. So very different handwriting between essential tremor and Parkinson's disease. What's also different is the progression. In essential tremor, we see the progression is very slow over years, over decades. In Parkinson's, we do see that it progresses faster, again, over decades, but a little faster. The average onset of Parkinson's tremor or Parkinson's symptoms is 65 years of age, and it does tend to progress faster than essential tremor. Now, how do we diagnose them? Interestingly enough, in this day and age, we don't have any single test that will tell you you have Parkinson's or you have essential tremor. The diagnosis is still a clinical process. What that means is that you need to see a neurologist. The neurologist needs to perform a neurological exam. And we use, or even better, a movement disorder specialist, which this is what they specialize in. They specialize in tremors, essential tremor, and Parkinson's. And we use specific scale to rate the tremor and understand what type of tremor it is. Is it essential tremor, is Parkinson's tremor, or some other type of tremor? So the clinical assessment is the most important, and that is what will set the diagnosis. Clinical history is also very important. So I will spend a slide on discussing about what it is that you need to talk to your doctor, tell your doctor to help them arrive in a diagnosis. We've progressed a little bit with imaging to help give some clues towards diagnosing essential tremor or Parkinson's patients. These are called DAT scans. Very, very simply put, it really shows the dopamine concentration in the brain or the dopamine activity in the brain. This will help and does help us differentiate between Parkinson's from essential tremor. Sometimes the symptoms are very, very difficult to discern between one or another. And DAT scan is what it will help us. In a patient with Parkinson's disease, the DAT scan will be abnormal. It will show that the dopamine activity is low, whereas the essential tremor patient will have a normal DAT scan. Dopamine activity is normal because the dopamine is not affected in people with essential tremor. We do have a newer test that has emerged over the past few years, and this is the alpha-synuclein test. This is tested in spinal fluid or skin at this time, and it does show some promise for early detection of Parkinson's. Alpha-synuclein is a protein that we find is accumulating on the skin of people who have Parkinson's. So if we get a biopsy of the skin, we can that contains alpha-synuclein protein that leads us to closer to the diagnosis of Parkinson's. Same thing goes for spinal fluid as well. Now, bear in mind that we need all these tests because misdiagnosis is very common. Up to 1/3 of patients were initially diagnosed with essential tremor, And these patients may be later reclassified or re-diagnosed as having Parkinson's disease. The reason for this is, again, it's a clinical assessment. So the question is, who is assessing you? If someone who has experience and extra training for tremors and for Parkinson's disease or essential tremor, they will have a higher precision in the diagnosis of either disease. However, if the physician who's diagnosing you is someone who doesn't really treat or diagnose or has not had proper training for these disorders, they may be not able to give an accurate diagnosis. So how do we diagnose these conditions? Medical history is very important. Please let your doctor know what the symptoms are, when they started, how they're affecting your life, whether your family had symptoms such as tremors or any unsteady gait, voice tremors, etc., whether you're taking any medications or whether you started any new medications, any other conditions you may have. The neurological disease is the hallmark, is what will set the diagnosis. And also your doctor will ask you to do some performance tests. For essential tremor, we all ask the patients to attempt to write and also draw spirals to look at how these are, whether the tremor comes out. We ask you to hold your arms outstretched, also do finger to nose movements, attempt to drink from a cup, things like that, trying to bring out the tremor if we're suspecting essential tremor. We also use tests to exclude other conditions that may be mimicking tremor. Thyroid issues. If your thyroid levels are very high, the tremor will come out. If there are any metabolic problems, any medication effects, these can bring out tremors. So you may have excessive tremors and be erroneously diagnosed as having essential tremor, where the problem was actually a drug or a medication that you took. So it's very important to know what mimics tremors, or what are secondary causes, as we call it, secondary causes of tremors. Medications. Know that certain medications such as asthma, which are very common, asthma medications can cause tremors. Any antidepressants, also known as SSRIs or SNRIs, these are also causing tremors. Anti-seizure medications, some can also cause tremors. Metabolic issues, thyroid, liver or kidney failure, we see it very commonly. Patients have tremors. Or if you're diabetic and your blood sugar is low, it can manifest as tremors. So always have that in mind if you're worried about having tremors, or if you're seeing your doctor about tremors. There's another condition called enhanced physiological tremor. We all get a little bit shaky when we get in situations of extreme stress. So stress can exacerbate or bring on tremors. That doesn't mean we have essential tremor. This is a normal physiological response of the body. If we're very anxious, if we haven't slept, we're sleep deprived, fatigue can also cause it. Or if someone goes to the gym and exercises or over exercises, they might find themselves having a little tremor. Again, that is not abnormal. That is expected. If someone's drinking too much coffee, or if they're drinking too much alcohol, the withdrawal of alcohol will bring on tremors. These are some of the tremors that are caused by external factors, and it's not because you have essential tremor or Parkinson's disease. And then there's some other neurological disorders that can trigger tremor or may present as tremor. One type of tremor we call it dystonic tremor. Dystonia is a constant contraction of the muscles. So if someone has a dystonic arm, we may feel that they also have a little tremor. We call that dystonic tremor. It is not essential tremor or Parkinson tremor. There are other conditions. If they've had a stroke in the cerebellum is the area of the brain that controls coordination, we will see that those patients might have a little shaking. Or if they have nerve damage, neuropathy, that can also cause shaking and tremors. So how do we approach tremors? Essential tremor and Parkinson's have two different ways of therapies. In terms of essential tremor, we do find there's two medications that they're very effective. However, they come with side effects. The one is beta blocker, most specifically propranolol, which is the first line treatment. Side effects is decrease in blood pressure and heart rate. So we have to monitor that. And sometimes patients are limited and we can't increase the dose for better control of tremors because their heart rate is low. There's also anti-seizure medications such as primidone. Primidone is the most effective one. Unfortunately, we cannot use it in some patients because of the side effect of sedation. So the patients feel very tired, so they can't function during the day because they feel sleepy. There's also some others, but they're less effective, gabapentin, topiramate, etc. And last but not least, benzodiazepines can also be effective. However, it's only for short use because they're addictive and have a lot of side effects. Now, if any of these or a combination of these are not effective to control your tremor, then we need to move on to advanced interventions. There's a few. One of them is deep brain stimulation, who was approved in 2019 for control of essential tremor. This is a surgical implantation of electrodes in the area of the brain that controls tremors. It's simply putting it as being the pacemaker of the brain. It's a constant stimulation of that area of the brain controlling the tremors. Focused ultrasound, which is a non-invasive lesioning of the brain tissue, again, lesioning the area of the brain that is controlling tremors or causing tremors, so to speak. And also Botox injections have been effective if Botox is injected in the muscles that are moving the hand to cause the tremor. It is also very effective for voice tremor as well. Physical therapy can help, and some other supportive therapies can be helpful for essential tremor. But remember, treatment in general is we seek treatment if it affects your quality of life, your work, etc. So there are plenty of options for therapies for essential tremor. But what about Parkinson's disease? Things are a little bit more complicated there, meaning we have more options. The first line treatment for Parkinson's disease is medications. And we have multiple medications to choose from, starting with, of course, the most effective being levodopa. Then we have dopamine agonists, MOB inhibitors, some other type of categories of medications, and most lately, the subcutaneous continuous dopamine pumps. Lifestyle modifications, we know that regular aerobic exercise is very, very helpful and slows down the progression of the disease. If patients have balance problems, physical therapy with balance training is very helpful. But if any of these two therapy options are not effective and the patient's symptoms are not well controlled, then we think about advanced therapies and most importantly, the surgical interventions. So deep brain stimulation is one for medication-resistant tremors or side effects of medications such as dyskinesias or uncontrolled rigidity and bradykinesia. And MR-guided focused ultrasound is also helpful for Parkinson's disease symptoms. Other supportive therapies, physical therapy, speech therapy, occupational therapy should be included in the patient's general therapy for the tremors and for symptoms of Parkinson's disease. So, how do you approach your tremors with your doctor? Before your appointment, keep a symptom diary. This is extremely important. Keep the timeline of your symptoms. When did they start? How did they start? What were the circumstances? Which side was it? Which side did it start? How often do you see the symptoms? Are they constant? Do they come and go? Everything around the symptoms. Record videos. Videos of tremors are very helpful for us to get a better sense of the type of tremors you have when you're at home. List all the medications, document your family history, and write down any questions or concerns you may have. During your appointment, again, describe the tremor. If you can make the tremor come out, just do this in front of your neurologist so they can see it. It's also very important to tell and explain your doctor how your tremors are impacting your life, your work, your social life, your hobbies. That is very important because that will help us understand how aggressive or not we need to tailor your therapy. And then ask about any diagnostic tests, any clinical trials ongoing, and talk about the treatment goals. Decide this with your doctor. Be an advocate for yourself and your therapy. And request a referral to a movement specialist who are the experts about recognizing, diagnosing, and treating tremors. So in conclusion, this conversation is to empower your journey. The key takeaways are essential tremor and PD tremor. They share symptoms, are very different in what causes them, the progression, the treatment approaches. Be your own advocate. Open communication with your doctor. Make sure you have all the information that your doctor needs to know about your tremors, your medications, your family history, etc. And just know that there's multiple treatment options for either tremor, whether it's essential tremor or Parkinson's disease tremor. And there's more coming in the horizon. So just remember you're not alone. And these webinars such as these and any resources are available to help you live with tremor. This is our team here at UT Health San Antonio. This is our movement team. And we are growing, very, very excited. We have research and a lot of webinars and outreach and educational courses going on, and a very, very strong surgical department with Dr. Papanastasio, who is performing deep brain stimulation and focused ultrasound surgeries for our essential tremor, Parkinson patients, and dystonia patients. So for any questions you may have, I will open it up with Dr. Papanastasio as well. Thank you so much for your attendance, and happy to take questions. Both Dr. Papanastasio and I will be happy to answer any questions you may have. And please use our contacts if you have any questions to contact us.
Thank you so much for all that information. That was wonderful. I want to remind the attendees that there is a Q&A button at the bottom middle of your screen. That is where you can type in your questions. Unfortunately, we can't have you raise your hand or just speak into the microphone. So if you wouldn't mind typing those questions in now, we'll take a few minutes to answer whatever questions you do have. Okay, sorry about my dogs. Here we go. First question is, how do you decide when it's time to consider DBS versus focused ultrasound? I believe this is probably Dr. Papanastasio.
No, I'd let Dr. Vaou start off because she's often following the patients for a long time in the clinic thinking about this exact question.
I think this, yeah, you're right. But I think this question is for both of us. I'll start. Thank you. So there's, I love having two options because it really gives the patient what we call individualized therapy. It is a patient preference in many ways. It is also whether the patient is a good candidate for either or, and also thinking about the disease. What will be better suitable for the patient, for the disease, and knowing the benefits and risks. This is a big conversation that I have with my patients. We movement specialists have with our patients in our office. And then also I urge the patient to have the same conversation with Dr. Papanastasio, with a neurosurgeon, from the surgical perspective. I can go into details, but Dr. Papanastasiou will tell you more about the scalp and all these things and the density, but balance is one thing that we consider with essential tremor. If patients have a poor balance, we're a little bit more hesitant to recommend focused ultrasound, and we move more towards deep brain stimulation. But overall, again, we're looking at the whole picture and what the patient wants. So Dr. Papanastasiou, back to you.
Okay, so I see that there's a one comment about feedback. I don't know. I actually don't hear any feedback. Do you, Kara or Dr. Vaou? Because I hate to have people if they can't hear as
I
well.
do not.
Okay, so it might be a local issue for that listener, so we apologize for that. Maybe turn the volume down. That sometimes helps, but I'm not hard to troubleshoot. So I'd like to echo a lot of what Dr. Vaou said, that I think is definitely very much a personal decision. And when I have patients come to the clinic, I often make the point that this isn't like a brain tumor or brain aneurysm or coronary artery disease where you come to your doctor and they tell you you need to have this treated or not because it's a life or death issue. With tremor, it's not a life or death issue, of course. It's a quality of life issue. And so the big question is how much it affects one's quality of life. Now, of course, if the tremor is super mild and slight, well, then we wouldn't recommend a surgical intervention just because we know that something that's slight would be hard to make better. But it's very rare that somebody's coming in wanting to consider surgery when they have a slight tremor. So for the 99.99% of people that are coming in with a substantial tremor, the question becomes, well, how much does it affect your daily life? And I always bring up the example that on one end of the spectrum, I might have somebody with a very, very severe tremor and they say, well, it doesn't bother me. I just use a sippy cup and my wife cuts my food for me and I'm perfectly fine. And another person who maybe has a less severe tremor who might say, well, I can't eat or drink. I live on my own. I'm embarrassed to go out in public because everybody's always staring at me and it just makes me feel uncomfortable to be out in public. Shaking, so I haven't been out to eat in 5 years, and I can no longer do my main hobby. Name what your hobby might be that requires hand function, whether it's knitting or crocheting or painting or whatever it is. And so you can imagine that there's a whole spectrum between those things. And I always say that it's our job to say, is the tremor bad enough to treat? And then it's the patient's job to say, well, is it worth treating? And part of what plays into that are just the risks and benefits of the procedures. And so just briefly, with a DBS procedure, it's about 0.5% or 1 in 200 that we cause an injury to the brain. So it's safe and it's a low risk, but you certainly wouldn't, take it lightly or do it if it wasn't, causing a significant impact on your life. With focused ultrasound, we tend to say it's about 1% chance of a permanent problem, but it often can be very mild. So it's a little bit of apples and oranges. On the one hand, the percent for a problem with DBS is lower. It seems that the focused ultrasound, when a problem happens, is quite mild. So you can, people could react to that information sort of either way, right? Some people would say they'd rather have the lower rate and don't mind having a surgery with an implant. That's the DBS. Some people would say, well, those rates are both pretty low and I'd rather not have surgery or an implant, and I'd rather something that doesn't have an incision. So people can kind of go either way. And I have to say, it's kind of lengthened the clinic visits since focused ultrasound became available, because we wind up going through, well, what's the procedure, risks, benefits, and recovery for each one. So it kind of doubles our clinic visit time. But I agree with Dr. Vaou that it's nice to have both options. And there are definitely people who come in and hear about it, and they came in interested in focused ultrasound and switch over to DBS, and vice versa. People that thought they were interested in DBS, they come in and they say, well, that focused ultrasound sounds better. And so I always try to, just kind of help people through the decision-making process to find out how they feel about it. And a couple of things that often come up, people say, well, do I need to have this now because it might get worse? And so, like, essential tremor has a usually slowly progressive course, and so does Parkinson's. But I usually tell people, don't worry, there's no age that's too old. So you don't want to have it preemptively. You want to have it at the right time when you need it. And you're not going to get too old to do it. And what else are the usual? That's kind of the usual ones that come up. So I'll kind of, I think, pause there.
And in terms of timing, I just want to add one more thing that I tell my patients is, like, why wait and why waste your wonderful years struggling with your tremors if you can correct them now?
That's a great point. Sorry, my version of what Dr. Vaou just said is to say things like, well, if your tremor is really bad and you're likely going to have the procedure anyway, why not have it earlier and have the benefits earlier? So I certainly don't, it's funny too, because what Dr. Vaou and I see is that sometimes people are much more enthusiastic about it when they're talking to their neurologist. And then sometimes when they're meeting a neurosurgeon, then all of a sudden things get more real. So I'm used to people getting a little scared, which I think is appropriate, right? It's safe and it's low risk, but it's still brain surgery. And but then people either talk to other patients, talk to Dr. Vaou and me or whoever among our movement disorders team, and get comfortable with things.
Wonderful. Thank you both for that information. That was great. Next question is, what lifestyle changes can help me manage my tremor symptoms?
Well, a few things. Think about what you consume. So if you drink 5 coffees a day, you might want to consider that and just use non-caffeine, non-stimulating beverages. Or sometimes people on amphetamines, for example, for ADHD, that causes a lot of tremors. So you might want to choose something that might be a little milder. So that's more the medication, the health issues. Someone I see in the Q&A asked about thyroid, what test to do. Make sure you do a TSH and thyroid hormones, the function test. That is your primary care provider. So kind of go over these things, making sure, eliminate anything that makes your tremors worse. If you have anxiety, coping mechanism, meditation, things like that will definitely help. But if you have true essential tremor or Parkinson's, other than your medication, your treatments that we talk about, because you're asking about lifestyle modification, exercise is extremely helpful. Physical therapy or using these some certain wearable devices, not that they're wearable as in this wearable, but weighted devices that can help with the tremor. These are some of the things that have been helpful in addition to medications or in addition to interventions and intervention therapies. That being said, and not because we're having this webinar under Inside Tech, but I have to say that 2 things. One, if you are considering deep brain stimulation or focused ultrasound, you have to have tried and failed medical therapy for your tremors. And number 2 is that those advanced treatments, the surgical treatments, will control the tremor most likely much better than the medications will. This is kind of what we see across the board.
I wanted to chime in on what Dr. Vaou was just saying, because I was having the same thought as you were answering the question. I know it's not about lifestyle changes, and I really appreciated hearing your thoughts on those. I think that I wanted to make a comment on the medication trials, because just like Dr. Vaou said, so insurance companies pay for both these procedures, all insurance companies do, but you have to have tried the medicines. And I talk to a lot of patients who think that trying the medicines means that you have to be on them for years and years. And that's not the case at all, right? If you take the medicine and titrate up to a certain dose and you get a side effect and it hasn't controlled the tremor enough, that counts as failure, even if it's been 1 day or 1 week or 1 month, right? And same thing, let's say that you titrate the medicine up, you get to the highest recommended dose, and you don't have good control of your tremor, and that's pretty common. Dr. Vaou can probably tell us the percentage. I think it's about half of people or so. Then that means you failed, right? It didn't work. Not you failed, but the drug failed, right? And so that also doesn't need to take much time. And I know part of the goal of this webinar is to help you advocate for yourself as a patient. So let's say that you're going to your primary care doctor and they put you on the lowest dose of primidone and your tremor, you don't have a side effect, but nothing's happened with your tremor. Well, you make your follow-up appointment and you go in and you say, hey, can I try the next dose up? I want to try something that works, right? And I know, Dr. Vaou is very humble. I'd like to also just put a plug in there. What I tell patients all the time, if I meet them in the supermarket or, friends of the family, all that, as I say, sometimes the wait for a neurologist can be long because they are very in demand, but our wait is actually pretty short right now. I think we're at like 6 to 12 weeks or so. But what I always say is it doesn't actually matter how long the wait is. If the wait is 1 month, 3 months, or 6 months, and you've got tremor that's bad enough that you're going to your doctor to get treated, just get yourself a referral, and you're still going to have tremor whenever that appointment is, whether it's in 1 month, 3 months, or 6 months, and then you'll be able to get their expert advice. And you can just imagine the difference of talking to someone like Dr. Vow, who spends her entire life treating tremor and movement disorders and knows the ins and outs of every one of those medications and every one of those doses and every one of those side effects and every one of those conditions and other medicines that might be impacting the tremor, compared to, your general primary doctor, who has to spend, their lives treating every medical condition, and they may know a ton about, diabetes and heart disease risk factor management and primary care, but an essential tremor, while very common, they're definitely not going to have the same level of expertise. So I always recommend, get started with your primary doctor, and in parallel, get yourself a referral to a movement disorder specialist. And of course, when the appointment comes around, if the primitive's knocked out your tremor and you don't need them, you just go in and get their advice of what if it ever stops working, and it's a short visit, no big deal.
Thank you.
Yes, thank you both. That was wonderful
Agree.
information. Thank you for that. Next question is, how much physical activity is recommended? Duration and intensity?
Depends for what cause. For Parkinson disease, the studies have shown that if you get anywhere between 30 minutes to an hour every day, 6 days a week, roughly on average, that is the desired goal. But I think that applies for everyone. So the more the merrier. Of course, you don't want to overdo it, but it definitely has neuroprotective properties, exercise does.
Can I chime in on that one also? Dr. Vow certainly has more expertise on overall, but one of the things I think is key to recognize is that I always tell people that it's great to find an exercise program that you can stick with and that you like, and that even going for a brisk walk for a half hour to an hour counts. That's good enough. So if you like walking in your neighborhood, that's good. Obviously, if you want to join a gym or do boxing or take up a sport, or do whatever, any of those things is fine. But I think the key to having successful, long-term success is just picking something that you enjoy doing.
Nice. Thank you for that. Thank you both. Next question is, how do you feel about CBD for tremors?
So what I'm going to say is it's anecdotal. There's no good evidence about the benefit. There is a benefit, but it's short-lived, and it's not something that is generalized. We don't prescribe CBD. We don't recommend it. We will not say do not use it, but we have seen that it does help with tremor, but not to the point that, again, it's very short-lived, so not to the point that what we currently have as treatments, they're not superior than our current treatment, is what I'm trying to say. So that is general where we stand as a medical community. If I know there's being clinical trials done to look at the efficacy, the safety, and once we have more data, we're happy to share.
Thank you for that. Next question is, what are the earliest signs that distinguish essential tremor from Parkinson's?
Well, there's motor and non-motor. In terms of Parkinson's disease, we also see some non-motor symptoms come out first, such as acting out of dreams early in the disease, even 10 years before the tremors start. Slight autonomic dysfunctions such as constipation, decrease of smell, the sensation of smell. These are some of the symptoms that we see in the prodromal area, prodromal time of Parkinson's, in which case essential tremor doesn't have a prodromal, or at least we don't know of one, a prodromal phase. So what we see with essential tremor, it will start very insidiously, starting with a little bit of a tremor, and it might come and go, fluctuate in times that people might be more stressed or tired. They might see more tremors. So sometimes when they're doing totally fine and on vacation, the tremor will go away. So a little fluctuation, and that it will progressively get worse, but no prodromal symptoms that you see in Parkinson's. Now, in Parkinson's, the tremor usually starts in one hand. Sometimes it starts with a little thumb tremor, and again, it stops. people are like, maybe, you know, I hurt my hand and this is why I have a tremor. They start by giving some excuses, and then that tremor becomes more and more constant during the day. But again, it's only resting tremor, one side only in the beginning, and that is the Parkinson tremor. These are the differences.
Excellent. I appreciate that information. Next question is how do you recommend patients cope with the emotional impact of these conditions?
That's a very good question. There's different stages in both of the conditions that there's different emotional reactions. The initial phase and the most difficult phase, I think, is the diagnosis phase. So getting diagnosed with Parkinson's or essential tremor, there's different types of patients. Some are in denial. Some don't want to try therapy. Some think it's not that disease, it's something else. So acceptance is sometimes needed. Time can help patients accept it better, or therapy is very helpful, and we do provide it in our center. And then also going into surgery, that's another phase where sometimes some patients see it as defeat. They see it as, oh, I'm advancing, therefore I need surgery. They think it's their life is coming to the end. However, it's not a last resort therapy as it used to be, right? So surgical therapies, we see them being used more and more these days in kind of moderate disease, what Dr. Pavanasasi and I are talking about, when the symptoms are affecting your quality of life. It doesn't have to be that way. There's these advanced treatments that we can now use to help you live another 10, 15, 20 years with a good quality of life, not struggling with your tremors. So I think these are the phases, and definitely emotional support, family support, social support, and psychological support through a therapist can help you push through and come into acceptance, but also move on to accept treatment and fight for the disease.
Fantastic. I like the way that you put that. That was wonderful. Next question is, when trying to determine if hyperthyroid is involved, which thyroid test or tests are appropriate?
Lab tests, like I think we talked about, the TSH, thyroid function, thyroid testing is the first thing. Talk to your primary for that. Sometimes an ultrasound of the thyroid may be needed, but that's all primary care, family doctor.
Gotcha. Thank you. This question says, do you have a copy of the presentation that I could give to a friend who has recently been diagnosed with essential tremor? So I can say we are recording this.
I think that's our plan, right? Is to make it available. We do have a link to some of our old, recent previous webinars on focused ultrasound that I did. And so I think our plan was to put these online, at the UT Health website. So yeah, we'll try and make those available. Do you have any other comments on that, Kara? I know we give out the link when people ask for it, so you can always contact, focused ultrasound at utusca.edu. Or I see Dr. Vaou's email right there. She might prefer if you call.
And this says that UT will be putting it on the focused ultrasound page.
Okay, great. So we'll put it there.
So it will be there. Okay, that looks like there are no other open questions. So I just want to thank you both today for your time and your expertise and all this great information. I want to thank everybody who joined this webinar today for your attendance. And we look forward to, this is a series, so we look forward to the upcoming webinars that you two and the rest of your team will be presenting. So thank you again so much. Everyone have a wonderful day.
Thank you, Kara. Thank you, everyone, for listening.
Thank you.
Really appreciate it.
Thanks, everyone.
Bye-bye.
Bye.